Boa tarde, pessoal. Estamos entrando ao vivo. Eu vou falar em português só até o Dr. Fung entrar. É a primeira vez dele no Instagram, então a gente vai ter que ter paciência, tá? A partir do momento que ele entrar, eu vou começar a falar inglês, mas depois a gente vai traduzir para vocês. Então não se preocupem com a tradução, ok? Então vamos esperar o Dr. Fung chegar. Expectativas estão altas, vamos ver se ele vai conseguir. Ele é mais um fã de Twitter do que de Instagram, então a gente tem que ter paciência. Tá todo mundo me ouvindo bem? Preparados? Pessoal, outro aviso, eu vou inativar os comentários, tá bom? Porque senão eu não consigo me concentrar. Uma hora eu fico mais acostumada com esse Instagram, mas ele chegou. Então vamos dar boas-vindas e adeus português. Hello, Dr. Fung.
Oh, hi, how are you?
I'm good. Did you have a good time joining Instagram Live for the first time?
Yeah, I tried to do it on my computer, but I don't think it works on the computer, so I switched to my iPhone. It seems to be okay.
Much better. Can everybody hear Dr. Fung well? Yeah, apparently yes, so we can begin. Well, Dr. Fung, thanks a lot for being here. I'm a little nervous for speaking English. My English is a work in progress, so I'm sorry about that. Well, guys, today is my pleasure to be joined by Dr. Fung. I bet most of you know him, and he dismisses any introduction, but anyway, he's famously well known about implementing therapeutic fasting to reverse diabetes, PCOS, fight obesity, and also reverse metabolic syndrome. And I had the pleasure to meet him in person about 2 years ago when I visited IDM clinic. And ever since we've been in touch. I was part of the Physicians Network, which was something that I learned a lot about, discussing fasting cases among doctors that apply fasting among the world. And after that, we began bringing fasting methods to Brazil from IDM Clinic. So it's a pleasure to have you here, Dr. Fung.
Thanks for having me. This is great.
So, Dr. Fung, I'm going to begin with a question that most of non-doctors don't know about it. So I think it's important for us to talk about it. So despite you having learned med school in Toronto and finished your training in America, and I'm being from Brazil, we both have something in common that is really important to talk about, which is nutrition training during med school. So I'd like you to talk about your nutrition training and what do you think of it right now?
It was very minimal. So what we did in medical school, there's a certain number of hours that are required during medical school for nutrition. But they don't actually talk about what most people are interested in, which is sort of food and stuff. They talk a lot about like vitamins, vitamin K deficiencies, and vitamin C deficiency, B deficiencies, and all that kind of thing, which is great. It's important. They do lead to a lot of diseases, but they're not really the diseases that we see a lot of. Like, we just don't see a lot of scurvy, and we don't see a lot of rickets and stuff. In the past, they were very important. Vitamin D deficiency, for example, causes rickets. So that's the stuff that you would learn about in medical school. But most people are more interested in is sort of like, how are you going to lose weight? Because, it's a strange situation, because every person knows that if you are overweight, you're at high risk of a number of health problems, type 2 diabetes, for example, but also like cancer and heart disease. I mean, that's well known. Like, you don't have, it's not controversial at all. Type 2 diabetes puts you at risk of eye disease, retinopathy, kidney disease, nerve damage, amputations, and all kinds of things. So it's very strange, because it's like, we know on the one hand that if you lose weight, your type 2 diabetes will get better, and then therefore your health will get substantially better. On the other hand, we learn very, very little about how to lose weight. And that's the real problem, and that's what most people are interested in. Sometimes for health reasons, sometimes for other reasons. They just want to look good, or they want to fit into their clothes better, whatever it is. And that's not something that is actually taught to doctors. And that's a real shame, because it actually is a extremely important part of what causes disease. And yet doctors know almost nothing about it. It's a strange situation, because you wouldn't, it's the last thing that you would expect. Because the problem is that as we move to the 21st century, the diseases that we face now are much different than the diseases we faced, 100 years ago. Back then, you're talking about trying to deal with infections, so you need antibiotics and viruses and HIV and stuff like that. And now we mostly deal with things that are chronic in nature and metabolic in nature. So if you know that these diseases, so heart disease, cancer, are the two biggest causes of death, really by far in North America, one of the biggest risk factors is how much you weigh and whether you have type 2 diabetes. So it's like, how can we not know about this? It's a very strange situation, why we continue to ignore this. And, I went to med school a while ago, but I hear this from graduates that are coming out this year, practically, people in medical school. They're like, yeah, we just don't know any of this stuff. I'm like, all this sort of antiquated notions of, what foods we eat, eating a low-fat diet, and what causes obesity, and we still recommend the same sort of old style diets that we had in the past because we never bothered to learn about it. It's a very strange situation.
Yes, I have lots of colleagues that ask me, well, where did you get that information? We never learned that at med school. And you're an anesthesiologist. How come you treat fatty liver disease and reverse type 2 diabetes? And I say, well, nothing of what I learned was from med school, and it's a real shame because it makes medicine a very frustrating profession. Like, most of my friends are a little burned out because you never get to see patients get any better, and then suddenly changing lifestyle, the power is so much bigger than using medication, that you recover your hope for being a doctor. And I think that to you too, because fasting in Brazil is something that is really cheap. Well, not only in Brazil, but especially for our economic situation. It's something that I think that it has to be explored, and that's why I went public on my Instagram. And I'm really a fan of your job, because I think you make everything sound so obvious and simple, not only to the doctors, but also for the people who needs to get better. So I think your job's amazing, and I thank you for that. You. But I would like to hear if you are very optimistic, because I'm not very optimistic at the moment when we're talking about pre-diabetes, because insulin is still very ignored in the medical field as something that we can address and prevent type 2 diabetes with 10 years ahead. It's like we have a crystal ball and we're throwing it on the ground. So I'd like to hear from you what you think about the progression of everything that we know and we're still ignoring.
Yeah, I actually am fairly optimistic, just because we see that there's a lot of attitude change with regards to various diets. So when I trained, of course, it was the low-fat diet was sort of the standard, and it was not very good for most people. And so thankfully we've sort of moved on from that, but we see real change. So you see, of course, the popularity of low-carb movement and also ketogenic diets, very, very popular, at least in North America, like in, Canada and the United States. And the other thing is intermittent fasting is really gaining a lot of traction. So when I started talking about it, sort of 2012, 2013, boy, everybody thought I was completely insane. Really, everybody thought it was the dumbest thing they had ever heard. And now, of course, people are starting to shift. You see a lot more messages out there that, hey, this is something that we can do. And I always talk about intermittent fasting. I always say, well, first of all, it's different from diets. Diets tell you what you're supposed to eat, whereas intermittent fasting tells you about the time, like the time that you want to set aside for not eating, for example. So it really tells you nothing about what you want to eat when you eat. So it really can apply to whichever diet you want to apply it to. Now, there are certain diets which I think are better than others, but, people have their preferred diets, whether it's vegetarian or carnivore. Then, some are, you can do whatever you want and still add the fasting in. But the other thing, as you said, it's not only costs no money, it probably saves you money, but also it doesn't take any time either, right? It's not like if you're really busy, you can't fast. You can actually, it's even easier to fast because if you're busy, you're going to gain the time. And it's available like anywhere in the world right now. That is, once you hear about it, it doesn't matter if you're in Brazil or if you're in New Zealand or if you're in Canada, right? You can still do it. The minute you hear about it, you can do it like tomorrow or today. You can start all right away. So it's not something that is sort of like, oh, this is great, but I can't, get it sort of thing, right? Like some of these drugs that they come out with, they're great drugs, but they're expensive and you can't get them. So what's the use? That's not what fasting is. Fasting is available to anybody who wants to try it. It's free, it's convenient, and it's been used for thousands of years, right? It's been, they write about it in the Bible. They talk about it during periods of time. So in Christianity, during Lent, for example, you'll have talk all about fasting. Like, when I go to church, I remember always thinking it's very strange because around April time, during the homily, they'd always talk about fasting. I always think, this was about 6 years ago. And like, I use fasting a lot, but I don't think anybody else really thinks it's a good idea. And yet the priest was talking all about it every April that we talk about it. And then Ramadan and Yom Kippur. And so you can see all these various religions. So it's not something that, I just made up like all of a sudden. It's actually been there all along, and it makes so much sense. And it can help so many people specifically for what we are dealing with now, which is in 2020, obesity is a far bigger problem than malnutrition or lack of nutrition, which was a much bigger problem 100 years ago. And that's why it wasn't the right treatment for the right time. But you can't just be stuck in the sort of like the 70s or the 60s or whatever. You gotta come now and say, look, this is the reality of the situation. Almost all the diseases are linked to obesity. We have a great treatment that's been used, that's free, that's available. So why don't we use it, right? And there's no reason. There's actually no reason other than people don't know.
Exactly. I was going to ask you, my personal history with type 2 diabetes. I've suffered a lot with my family, amputations, liver failure, and malnutrition after bariatric surgery. So that's something that really moves me in a personal way. So that's something that the part that I think that I'm not very optimistic about it, because low-carb diets have been timidly been included in the guidelines, but for mainstream medicine, still the medications that increase insulin are still abroad, like very used still, and making people sicker. So I'd like you to say a few words, because I know lots of colleagues are watching right now. Many of them support you and are great fans, but half of them still don't know much about what's wrong in the treatment for type 2 diabetes. And I think that's very important, because we're not supposed to get anyone sicker. So I'd like to hear from you.
This is really important, and this also is very close to me, because much of what I do as a kidney specialist is actually type 2 diabetes. And the problem is that I think the way we approach type 2 diabetes is actually completely incorrect. That is to say that most people, when they look at type 2 diabetes, they say, well, it's due to the high blood sugar, which is causing vascular damage, which is causing all the other complications of type 2 diabetes. The problem is in 2008, 2009, there were several very large studies, the ACCORD study, the ADVANCE study, and the VADT, all of which have like 15 to 20 year follow-up now. And what they did was they randomized, as a randomized control trial, and they randomized one group to sort of intensive control, which was mostly insulin and sulfonylureas at the time, compared to sort of a more lenient sort of thing. And everybody expected that if you had very tight control of the blood glucose, that you would do better, less heart attacks, less strokes, that kind of thing. It was quite a surprise in 2008 that all of these studies, all three of these major studies, showed that there's no difference. So the paradigm that we had been laboring under, which is that it's if you simply give enough drugs to control the blood glucose, you will prevent complications, was proven completely false. And now we have 20-year follow-up, 15-year follow-up of the VADT and so on, 10-year follow-up of these studies showing the same thing. That is, controlling the blood glucose with those medications doesn't really work. And the point is, I think that you have to understand the difference between symptomatic treatment and treating the root cause. That is to say, you have to understand that type 2 diabetes is the disease and it causes the symptom of high blood glucose. Okay, so don't mistake the symptom of high blood glucose for the disease. Just like if you have an infection and you say you have a bacterial infection and you have a fever. So the infection is caused by a bacteria. The symptom is a fever. You don't just treat with acetaminophen and get the fever down, right? You can keep giving medications to get the fever down, but if you don't give antibiotics, you're not going to cure it. And we know that. So if type 2 diabetes is the disease, the symptom is high blood glucose. The high blood glucose is caused by the type 2 diabetes, and yet we focus all our treatment on lowering the blood glucose, but that's symptomatic treatment only. So therefore, you're not going to get better. So say you give somebody a ton of insulin, and what is going to happen? Well, their blood glucose will get better, but what's going to happen to their diabetes? Well, they're going to gain weight, because that's what always happens with high-dose insulin. And what happens when you gain weight? Well, your type 2 diabetes generally gets worse. So even as your symptoms got better, you made your disease worse than ever. And there was a great study done a few years ago where they took people with type 2 diabetes, not on insulin, and they gave them a high dose of insulin to get their blood glucose down. So they got their blood glucose to normal. They went for over 6 months from 0 units of insulin to 100 units a day. Okay, so 100 units a day of insulin. Their blood glucose was amazing. They all gained about 20 pounds of weight, even as they lowered their calories, because remember, the insulin is what's driving the body to gain weight. And then they measured their insulin resistance. And the insulin resistance was directly related to the insulin. So the more insulin you took, the more insulin resistance you got. So in other words, your diabetes was getting worse on treatment, even as your symptoms, their blood glucose is getting better. So that's the thing, is that don't lose sight of what you're treating.
Right?
Yeah, totally. Although it's been unfortunately it's standard of practice. But the thing is that I always thought strange is the patients knew it before the doctors knew it, because my patients would always say, "Hey, doctor, you told me to lose weight, and then you gave me insulin, and I gained like 25 pounds." And it's like, how is that good? And it's like, the answer was that it was never good. It was never the right treatment. It was making it worse. That is to say, let's step back a bit. And we know that type 2 diabetes is a disease characterized by too much insulin, right? Hyperinsulinemia. So you get insulin resistance, you get hyperinsulinemia. So why would you treat a hyperinsulinemic patient with more insulin? Like, that's insanely stupid, right? That's like having a patient who's, hypothermic, and then putting him in an ice bath. Like, are you trying to kill people? It's like, oh my God,
apparently,
like the entire physiology, apparently yes, yeah. The entire way we looked at type 2 diabetes was completely wrong, and that's why we could never make any progress, because the whole idea is that you're making a situation of too much insulin worse by giving more insulin. So if the disease is too little insulin, which is type 1 diabetes, then giving insulin is a very good thing, right? You're going to save lives. Just like if you're hypothyroid, you're going to give thyroid replacement. If you're hyperthyroid, you're not going to give it. So now if you have hyperinsulinemia, what you need to do is lower the insulin. You need to lower the blood glucose and you need to lower the insulin. How are you going to do that? Well, low carbohydrate diets work and fasting works. And guess what? When you don't eat, your blood glucose drops. And then if you keep going, you can actually reverse that type 2 diabetes. And is it proven? Absolutely. Look at all our studies of bariatric surgery. So you sew up somebody's stomach and they can no longer eat. What happens to their type 2 diabetes? Like 90% of it goes away. It just goes away. So it was never an irreversible disease, because we proved that with the bariatric surgery, because all those patients reverse their type 2 diabetes. So it's not irreversible. It proves that it can be done, but you need to know the right way. So if you simply fast, it's the same thing as bariatric surgery. It's basically bariatric surgery without the surgery. And we had a couple of case reports of the same thing, and there's lots of people out there who have said the same thing. Once they started fasting and they started understanding that you simply allow your body during fasting to use up all that glucose, well, they just start reversing. And you know, it's the weirdest thing is that you have to do this for the most part in spite of the doctors, not because of the doctors. You have to reverse your disease in spite of the doctors, and that's a really sad sort of state of affairs. But as I said, I'm hopeful that it's going to change, because I see more and more doctors like yourself starting to understand, hey, this actually makes a lot of sense. Like, it's not just some wacko person out there that's talking about fasting. I mean, there's real physiology behind this. Like, these are real issues. That is, like, if you're hyperinsulinemic, why give more insulin? How does that make sense? Like, tell us, right? That's the thing. And that's what we want to do. Try to reach more people, try and reach more doctors, so that they can see it from a different angle, so that they can say, hey, maybe we should do this. Because you know what? If you're talking about fasting, you're not talking about anything that's not available. Like, I can do it for my patients right now. I can help them. We have the fastingmethod.com, which is going to help people. And then, hopefully get some good information out there. That's why we're going to do those blogs, and, you're going to help us translate that into Portuguese and get it out into the, so that people understand, hey, this is something that is doable, that is helpful, that is great.
Even for type 2 diabetics that have been using insulin for more than 20 years, right, Dr. Fung? Your
so in our case report, it was
amazing, very inspirational.
Yeah, that was striking. I mean, 20 to 25 years. There are 3 patients, 20 to 25 years each of type 2 diabetes. I think somewhere on the order of 60 or 70 units of insulin. We started them on a fasting regimen, which was 24 hours, 3 times a week. And what was funny in these 3 cases was that they got off of their insulin between 5 and 18 days. It was like, whoa, some of these people were on 5 years of insulin, and we got them off like in less than a month. It was like insane. And, as they continued, they basically kept it all off. They never went back on insulin. Most of them became, non-diabetic. That is, their A1Cs dropped below the threshold of classifying them as diabetes. So 20 to 25 years of diabetes. And it actually reversed because, again, they were not on medication and their A1Cs were below 6%, and that is classified as non-diabetic. So it was insane. And that was, again, like you say, it sort of really reinvigorated my sort of passion for medicine, because here's something, that
you
we
really
were doing
changed someone's lives.
Yeah, exactly. Not with, anything other than the knowledge that we had and the support that we were giving people. We could really change people's lives for the better. And, that's why we do things like this and the blogs and the website and all that, to try and reach as many people. Because if the doctors, like the mainstream medicine, is not going to say, okay, this is something we need to do, then we're going to have to do it ourselves, right? I mean, because that's what we do as physicians.
Yeah, even the New England Journal of Medicine, the last review from fasting, it caught up a lot of attention here. And in the end of the review, they say, well, although fasting is very beneficial, it's not easy to do, so doctors are not supposed to shy the people away, but it's very difficult. So I thought it was a little weird that they said it, But then I thought, well,
Yeah.
not many people know how to apply fasting with experience on the main side effects and ways to do it in an easier way to make the patient apply that. And you and Megan are experts on that. And also, I think that the case series was a really great start because although fasting is ancient, we don't know much about dose. I'm an anesthesiologist, so I always
Yeah.
think about dose and response. And about fasting, we don't have many studies like measuring ketones, GKI index. So we never know how much fasting we need for how much insulin resistance and
Yeah.
obesity. And I think that was a great start because 3 times a week, 24-hour reverses. And I had the same results here as well. It's a shame that I didn't publish because all we need to
Oh,
do
took
is
a long
gather
time.
up, yes, it's gather up more data to reveal the world that this kind of dose is a big way to start with high insulin resistance. So I think it was
Yeah.
really important.
I think that's an important point because if you look at the studies from the 60s, when they talk about fasting, they were doing like 30 or 60 days at a time. It was like crazy. Like that was what they thought about. So what we're doing is completely different these days. It's a lot less risky by doing it 24 hours, 36 hours even. I mean, it's 36 hours, not 36 days, which is, something that they did way back when. So that's really important because the dose and the regimen is something that we really need to sort of say, oh, okay, well, what regimens work? This works, this works, this works. Okay, if you did 60 days, sure, that would work. But it's really not that easy, even from a social standpoint. So if you have other regimens that you can offer to people, that's important. And the other thing that's really important, again, as you say, is that, if it works, then our job as a doctor is not to tell people what they can or cannot do. Right. So if you have something like chemotherapy, which is very, very difficult, I mean, a lot of side effects, my job is not to say, well, you know what, chemotherapy is really hard, so you can't do it and you'll just die of cancer. Like, who says that, right? So if fasting works, like, I want to know if it works. If it does work, then let me make it easier for you. How are we going to do that? Well, there's lots of different ways. And, we're very, humanity, there's a lot of people with a lot of imagination. And we can come up with ways to make it easier. Because it's not like people haven't ever done it. People have done it. I mean, it's all throughout history. You see, people have fasted. Like every year on, Lent, people fast. Every year on Ramadan, people fast. Every year on Yom Kippur, people fast. So it is doable. We just have to make sure that we, give people the tools that they need to succeed, not sort of shut them down and say, oh, you'll never do that. I mean, like, imagine telling your kids, you know what, you're not very smart and you'll never make it, so forget it. You're like, well, why would you do that, right? So why would you tell people that? It's like, if it works, let me help you. That's what I think a better attitude is, rather than sort of being negative. Because I heard that a lot too, right? Even after I would talk to groups of doctors, they would say, you know what, that makes a lot of sense, but my patients will never do it. I'm like, don't tell your patients what they can or cannot do. Some will do it and some will not do it, right?
And I think it's very
the ones
different
who don't do it,
if you tell a patient that, well, you can reverse your type 2 diabetes, you can diminish the risk of heart attack if you skip a few meals a week. That's like a very completely different way of approaching fasting instead of, well, you're going to starve, you're going to spend a month without eating. So it's a question of mindset as well. Even Walter Longo proposes the fast mimicking diet. I think he's never tried a 3-day fast because he talks about it as like fasting is impossible, so let's mimic it. So what's your opinion on this?
Yeah, I mean, I think so too. I mean, I have nothing against the fasting mimicking diet, as in, I think he's done a lot of good science so that, he has proof that it works. So that's great. I think that's fantastic. But again, to me, it's like, why would I want to mimic fasting? Why wouldn't I just fast, right? It's like,
yes, you can fast for free.
Yeah, exactly. And it's like, once you get used to it, and I know this because I've done it and we've helped a lot of people through it. One, it's not easy, but if you provide a supportive community, yes, it can be done. And the point is that, the fasting is one of these things that is more mental than physical, truthfully. Because if you look physically, like physiologically, if you have type 2 diabetes and obesity, you have too much energy. Like glucose is a form of energy for the body fat is a form of energy for the body. So when you fast, you're going to use it. That's all. So physiologically, it's not a problem. There is lots of problems like hunger. There's lots of problems with boredom. There's lots of problems actually implementing it, but physiologically, it's not generally an issue for most people. So therefore, it's a mind game, and therefore, we can help people because people can do it. So yeah, I share your opinion. Like I don't mind if people want to do the fasting mimicking diet, but I'd rather just do it like easily. To me, it seems that this is a solution that can be used anywhere by anybody, as opposed to a fasting mimicking diet, which is, well, you have to be able to get it, and you have to be able to afford it. So again, if you can and it helps you, and that's great. I don't really have anything against it, but it's just one of these things that I don't think is as hard as people think it is. It's just a matter of doing it and getting people used to it.
Yeah, another point is that I think that for some oncologists to prescribe fasting for a very skinny, consumed cancer patient is very difficult. So I think that maybe it's easier to introduce the idea of mimicking fasting with supplies. So I think like for cancer patients, it works well, the idea, but for obesity, it's like we have a pandemic.
Yeah, exactly.
Like cheap solutions.
Yeah, and it's not just that, but there may be other benefits too that we don't know about with the fasting. Like people talk about, so an example is the autophagy that you get with fasting. So autophagy is this sort of very interesting sort of disease, prevention state where the body is sort of breaking down its old organelles and sort of recycling them. And it turns out that if you look on mouse models, for example, and you block autophagy, one, they can't fast because it's a mechanism that fasting activates in order to sort of generate energy. But the other thing that's really interesting is that they wind up, if you don't have autophagy, you wind up getting a lot of neurodegenerative diseases, which is very interesting because it's like it seems like the brain really requires this autophagy to sort of maintain itself in good shape, because it is a sort of this maintenance mode. And the thing is that this would have implications for something like Alzheimer's disease. That is to say, the brain is very sensitive if you don't have enough autophagy. So if you fast regularly, does this translate into sort of more autophagy, which translate into less diseases like neurodegenerative diseases such as Alzheimer's? Very, very interesting sort of hypothesis. There's not a lot of data right now to go on, but there's a lot of data in the longevity spheres showing that things like caloric restriction can extend lifespan, and fasting is another way that you're talking about. Yes, you can do a total, over time, if you're not eating, you're generally going to get less calories, which may translate into longevity. So again, interesting sorts of ideas that could potentially lead to all these other benefits that we don't even know about, like Alzheimer's prevention. That's so interesting. Cancer prevention. Cancer is another area that is just fascinating because, one, we've learned in the last 20 years that obesity is actually one of the biggest risk factors for cancer. So breast cancer, colorectal cancer are the main ones, but one of the big drivers of these obesity-related cancers is insulin. That is, if you look at a breast cancer cell, it has tons of insulin receptors and loves insulin. If you grow breast cancer in the lab, you need insulin. Otherwise, they shrivel up and die. So it's like, that's very interesting. If these cancers are really loving insulin, then if you really shut down insulin, like with fasting, are you going to prevent it? And there's some preliminary evidence that says yes. If women, for example, who fast regularly through the night, so they're talking 14-hour fast sort of thing, they have less breast cancer recurrence. So very preliminary data, but it's like very, very interesting, and say, hey, this may play a role in all kinds of diseases that we don't know
Even
about.
side effects from chemo, right? There's an
Yeah.
endocrinologist in Brazil, Janaína Koenig. She taught me how to, she showed me all this evidence about cancer, and I was really fascinated about it. We even went to Metabolic Health Summit this January, and it was really interesting, and fasting was something that was mentioned in all the lectures by all this autophagy power of lowering the chemo reactions and working as an adjuvant for cancer treatment, not only for prevention. I know it's very preliminary, but still it's very interesting to understand the power of fasting. And when you do it, you know that you're not only losing weight, getting metabolically healthier, but also preventing a lot of neurodegenerative diseases like Alzheimer, as you said, is supposed to be like a type 3 diabetes. And it makes a lot of sense because even the cognitive improvements happen when you lower the insulin. So I think there's a lot to discover on insulin. And talking about that, I'm gonna skip to another matter on your book with Nadia. She's been here twice in my Instagram to talk about it. And I once heard you say that PCOS is like replay of type 2 diabetes failure in the treatment. So I'd like you to talk about it.
Yeah, it's really interesting because PCOS is not a disease that I treat a lot of, so I don't deal with it a lot, but Nadia does, so that's why we teamed up to work on it. If you look at how the disease actually happens, it really all relates sort of back to insulin. So if you look at PCOS, the disease, polycystic ovary syndrome, you've got a couple of things. One, you've got the hyperandrogenism. So that is the sort of facial hair and male pattern baldness and that kind of thing. You've got the anovulation, and you've got the cysts on the kidneys. Now, if you look deeper into what causes this syndrome, then you can actually find that the reason for all this winds up going back to insulin. That is, insulin actually causes the increase in androgen, as well as a decrease in the sex hormone binding globulin, which increases the free testosterone, so it's more available. It causes basically it causes the anovulation as well. So if you have too much insulin, what you get is a follicular arrest. So follicles are what develop in the ovary. This is what in a normal menstrual cycle, you have follicles, and you get one follicle becomes a dominant follicle, which grows and grows and grows. Eventually it pops out, an egg goes in, and that's how you get pregnant. You have the egg and the sperm. So what happens when you have too much insulin is that your follicles, they grow and grow, but then they stop at a certain point, and that's called follicular arrest. And because they stop, the other follicles that are developing don't involute. That is, normally only one follicle develops and goes through. Everything else just shrivels up. So when you have follicular arrest, you have all these follicles which are developing, and then they stop. Because you don't have the egg being produced afterwards, that's why you have anovulatory cycles, which causes the infertility. But because you have all these follicles which have developed a certain amount but not gotten any bigger, they sort of persist, and that's what gives you the cysts that you get for the polycystic ovaries. So in essence, what you've come down to, and the pathophysiology has been worked out for a long time, is that you have too much insulin, which causes the polycystic ovaries. You have too much insulin, which is causing the anovulatory cycles because you're not getting the natural maturation. And you have too much insulin, which is causing the hyperandrogenism, which is the facial hair, the male pattern baldness, and that kind of thing. So it's like, okay, so the entire syndrome is too much insulin. Well, what's the solution? Well, if you go to a normal book on PCOS, the solution is to give Clomid or something like that, right? Which is a fertility drug. I'm like, hello, there's too much insulin. lower insulin and you're going to get rid of the whole thing, because that's your root cause, right? Again, people are conflating the symptoms for the disease. The disease is too much insulin, you got to lower insulin. It's not the disease is that I can't get pregnant. That's a symptom of the disease. So you can give Clomid or you can do in vitro fertilization to get pregnant. Yes, you can. Or you can shave and get labor, but you don't stop the actual process. That's the disease. The disease is hyperinsulinemia, lower insulin. And how are you going to do that? Well, low carbohydrate diets work, fasting works. So Nadia works with a lot of these, and she's like, I think she says she's had like 10 or 12 people get pregnant and had babies going through her program. It's like, that's fantastic. I mean, for people who have had trouble conceiving, it's an unbelievable mental burden. I mean, to go through in vitro and all this sort of stuff. And to know that you could have actually treated the whole thing and gotten it better, not just gotten the symptoms better, not just gotten pregnant or, whatever, but to actually reverse the disease. Because the point is that it's not simply you can't have a baby, which is a big blow as well, but you're also setting yourself up for sort of a lifetime of health problems with
you need to know that and all that. Yeah, you have high risk for the other metabolic spectrum, like metabolic syndrome spectrum. So that's a message we really have to talk about it. And your book is amazing once more, because it's very simple and accessible to all the women that think that having a baby solves the problem, and they don't have an increased risk for metabolic diseases. I have lots of patients that are diabetic right now, and they had PCOS and got pregnant, but still had the problem. So they always ask me, why didn't anyone tell me this? Because now we know.
It's crazy. I just remember I went a few years ago to a conference on PCOS, amongst other things, and they talked about treatment and so on, and the whole thing was all about fertility drugs and lasers for getting rid of facial hair and all this sort of stuff. I'm like, and I just remember thinking, boy, like, don't you want to, like, I know you must understand the physiology of this disease because you're doctors, you're specialists in this, so why aren't you addressing it? Because it's like, and it was very, very stunning sort of to think that, hey, here's what causes it, so then, but you're not treating it at all. It's a really interesting. So yeah, I mean, that's exactly, if I was a patient, I'd say exactly the same thing. I'd be like, why didn't anybody say this, right? And that's what we came up with. And the PCOS plan, the book, is really, I don't think there's another book that talks about this, like, anywhere, like, which is, to me, again, super strange, because it's like, why not, right? Somebody must, like, this is such important information if you're suffering from that disease.
Yeah, I hope you get it translated in Portuguese, because Brazilians really admire your job, and we don't have PCOS plans still in Portuguese. So hopefully you will be translated.
Hopefully.
And talking about symptoms, I think it's very important that we talk about eating less and moving more, because that's a myth that most doctors learn in med school, and we can't get patients to get better if we don't know how to make them lose weight, because losing weight is not aesthetics. And I'd like you to talk a little bit about the calorie deception, like everything that we learned.
Yeah, the whole calories thing is such a scam, honestly. It's
cemented in stone.
I know, and if you say that, calories are not, it's nothing but calories, and people, like, in the medical profession, they think you're automatically like a quack, because they can't understand. And I always think this is very strange, because if you simply say, okay, like, look, there's foods which are composed of macronutrients, proteins, fats, and carbohydrates. So yes, they have calories, and people always say a calorie is a calorie, but it's like, okay, but that's not what I asked you, right? I didn't say, is a calorie a calorie? What I want to know is, are all calories equally fattening? Like, are they all the same? Because you know that if you take a plate of cookies and a plate of salmon, even if they're the same calories, the minute you put it in your mouth, your body responds completely and utterly differently. okay? We can measure all these things, no problem. You eat cookies, your blood sugar goes way up, okay? That's not, that's not controversial. Your insulin is going to have to follow because it's got to force all that glucose up, right? You eat something like fatty salmon and avocado, for example, same calories. Your insulin's not going to go anywhere. Your blood glucose is not going to go anywhere because it's a lot of dietary fat. Yeah, and half an hour later, you're not going to have the low. So the hormonal response, and then, for example, if you eat salmon, you're going to have protein, you're going to have fat, so you're going to have satiety hormones like peptide YY and cholecystokinin, which are going to be released, but not with cookies, for example. So there's a completely different response in our hormones from two different foods that is completely irrespective of calories. So what is important about those calories? Like, does our body somehow detect those calories? It's like, no, there are no receptors for calories. Your body doesn't know how many calories goes in and out of your body, right? It's weird because if you look at any metabolic pathway, so go to the biochemistry textbook and say, okay, here's the metabolic pathway for glucose. And here's the metabolic pathway for amino acid degradation. And here's the metabolic pathway for fat. So dietary fat, for example, gets absorbed. It goes into the chylomicrons, which goes through the lymph to the blood, which goes to the fat cell, the adipocyte, and you activate LPL. There's a whole pathway. And it's been worked out for like 50 years. Nowhere in there is there calories. Calories are completely irrelevant. There is nothing that the body just doesn't care about calories in any shape or form. And yet we think it's the most important thing for weight loss. It's like, why would you think that? Like, it's really, really bizarre because it's completely unphysiologic. Because you have to remember that calories is a unit of energy from physics. A calorie is the amount of heat that is released when you put a food, like you put that salmon into a bomb calorimeter, you burn it, and how much energy is released. That's what a calorie is. So people say, well, it's the first law of thermodynamics. I was like, okay, that's also completely wrong because if you take in, so, the first law of thermodynamics says in a closed system, you don't create or destroy energy. But that has no relevance, again, to the human body. If you take 100 calories of food, you put it in your mouth and you absorb it, then your body can either store it as fat or it can use it to build protein. Or it could burn it off as energy and, increase your body temperature, for example, or use it to power your liver, your brain. So those same calories can have completely different things, and it still doesn't break the first law of thermodynamics. I mean, people talk about, they say body fat equals calories in minus calories out, right? That's the energy balance equation. And that is true, but always misinterpreted. So if you say that body fat equals calories in, calories out, you're assuming that the calories in, when you reduce those calories in, calories out, the basal metabolic rate remains stable. But it doesn't. It doesn't. This is, again, just ridiculous because we've known for 20 plus years that the metabolic rate does not stay stable. It goes down. When you reduce calories in, calories out goes down. So if you eat 500 less calories in and your body burns 500 less calories, you are not going to lose body fat. So that's not breaking the first law of thermodynamics. It's just the way the human body works. And that's why people don't lose weight when they try to eat less, move more. Because what happens is that the body simply changes. So you eat less, you eat 500 calories less, your body burns 500 calories less, and you don't lose weight. And then eventually you get tired of it, so you go back up a little bit on your diet. So you say, okay, instead of 500 calories less, I'm going to eat like 200 calories less. So you're still eating less than before. But your body is now burning 500 less. So even on that lowered diet, your weight is going back up. So again, it's not the calories that's important. It's an almost irrelevant thing. What's important is the hormones in our body that are telling us whether we're hungry, whether we're not hungry, what our basal metabolic rate is. That's what's important. You got to focus on the hormones because our whole body works on hormones. That's just physiology. It doesn't work on calories and physics. It works on hormones. We respond to hormones. If your insulin goes up, there is a predictable response as to what will happen. If your peptide YY goes up, there is a predictable response as to what is going to happen in the body, right? And different calories will do different things. So this whole idea of calories is so, like, the more I think about it, it's like the more stupid it seems. Like, it's so, like, juvenile.
We blame the patients not to follow our advice. It's just that it doesn't work. So fasting is very counterintuitive from what we've learned in med school, but it really works when you put it into practice. So that's something I would like to talk about, because in my Instagram, there's something that I get at least 10 questions a day is about, well, I began to fast and it's very easy, and now I don't feel like having breakfast anymore, like at all. Is it a problem with my metabolic, basal metabolic rate?
No.
So they're worried that eating, skipping one meal a day will make their metabolic rate go down.
Yeah, that's a very common question. So one, if you're fasting and then no longer hungry, that's good, because if you're trying to lose weight, now you're working with your body instead of against your body. That is, most diets, you're eating but you're hungry, so you have to fight that all the time. But if you're fasting and then not hungry, well, that's a huge advantage for weight loss. But the other thing to understand is that the reason those calorie-restricted diets, particularly the low-fat calorie-restricted diets, didn't work is that they didn't actually change the hormones that were important, predominantly insulin. Because people always forget, they look at their model is all wrong. They think of the body as sort of this one-compartment model, when it's really not. It's sort of like a two-compartment model. That is to say that your body has two sort of choices as to what to do. So if your insulin is high, you're in the fed state. So if you're eating all the time, and most meals are a various combination of carbs, proteins, and fats, but insulin is going to go up when you eat. So when your insulin goes up, you're going to use the food. That is, the glucose receptors open. Your cells are going to use the glucose that is coming from your diet as a source of energy. So it's not going to use the energy from your body stores. So your body can store it as body fat for simplicity. It's also glycogen. But we'll say body fat is a store of calories. So your body is going to, when you're eating, you're in the fed state, you're not going to use any calories from your stores of calories, that is your body fat, but you are going to use the calories from your food. When you fast, what you're doing is you're letting insulin drop, which is going to change you from the fed state into the fasted state. So your body now is going to stop using the glucose from the diet because there's no glucose coming in. And therefore, it's going to open up the ability to use your stores of calories. So you're going to have glycogen in your liver, which is going to break down. That's glycogenolysis. And then you can break down your fat cells as well as a source of energy. So what you're doing is you're changing your source of calories. That is, instead of using the calories from your diet, you're going to use some calories from your body fat. So if you normally eat 2,000 calories, burn 2,000 calories, now you simply don't change your insulin, eat 6 times a day, eat 1,500 calories. Remember, your body is now in a deficit of 500 calories. But because you're keeping your insulin levels high, you actually have no access to your body fat stores. So your body has no choice but to reduce its expenditure to 1,500. And that's why your metabolic rate has gone down. During fasting, it's completely different. What happens is that you switch your fuel sources. So now you're going to get, say 1,000 calories from your one meal because you're fasting. Your body's trying to burn 2,000. You're only getting 1,000. And you're getting 1,000 from your body fat. It's like, hey, perfect. What's wrong with that? Now your body's like, hey, that's what we want. Now I have 2,000 calories. Why would I need to reduce my expenditure of calories? And it doesn't. And that's why it will go on and keep that metabolic rate stoked, because it's now taking, you're opening up those stores of body fat. And again, this is something that's been known for like 50 years at least, right? So in physiology, we say insulin inhibits lipolysis, right? You can't break down fat from your fat cells if insulin is high. Why? because when insulin is high, your body thinks you're eating. It thinks food is coming in and wants to store body fat. So it's not going to burn body fat and store body fat at the same time. So you're either storing calories or you're burning calories, right? So if you keep insulin high, then you're going to constantly be storing it. That's the signal. That is the hormonal signal to store calories. So what you want to do is make sure your insulin levels fall so that you can actually burn it, because that's what we want to do, to lose weight, right? I mean, that's the whole point. And that's the difference between fasting and sort of calorie restricting. Because a lot of people also ask, well, if I eat once a day and I'm only eating 1,000 calories, isn't this a calorie restricted diet?
Yes, they're always worried about the calories.
Like, no, it's not a calorie restricted diet. You're taking 1,000 calories from your food and 1,000 calories from your fat, and then you go on. Or if you're fasting multiple days, you're going to take 2,000 calories from your body fat, and that's it. Your body is not restricted in any way. And that's the point. Remember, there's this whole, like, if you look at a lot of people who are losing weight, there's hundreds of thousands of calories of body fat, stored in that body fat. You're just letting your body use it. Yeah, it's not available, and that's the point. And this is what the fasting does that is different than just cutting calories. And that's why the calories sort of story is so dangerous. One, is really silly, but it's really dangerous because it keeps you from seeing what's actually happening, which is, letting your body use the stores of calories, right? And that's what's powerful about it, is that it's just sort of natural thing.
Yeah, it's the winter that never comes. We were already prepared. We were always prepared for that, but now with processed food being easily available everywhere we go, it's the winter that never comes. And we're always going our insulin high. Yeah. Dr. Fung, our time is very short right now. We only have 4 minutes. Instagram works like that. It's very blunt. Whenever you don't have enough time, we get cut straight out with no goodbyes. So the last question is something that I got lots of questions about. It is, what is your protocol? Your fasting protocol.
Yeah, so mostly I skip breakfast. I do that I'd say almost every day. And I don't even think when I started doing it, it was deliberate. I did it because I think I started mostly during medical school. I just was too tired, right? So I wanted to sleep. And I didn't really care. So I just rolled out of bed, brushed my teeth and rolled into the hospital. So I literally woke up 5 minutes before going into work, which doesn't leave any time for breakfast. So I skipped it for years. And that was, so then I wasn't hungry. So then I mostly skip breakfast. So that makes it easy, because then several times a week, I basically don't eat lunch, and that's a 24-hour fast. So that's mostly what I do. And then I have a few times a year, I try to do a longer fast, just because I know that there's going to be some sort of dietary
additional benefits.
Yeah, if the point is, if you do short and long, you're going to get both benefits. I don't know that there's any proven benefits, but hey, if there are some and I don't know about it, I'd prefer to get them. But the other thing is that after like holidays and stuff, I'm usually way off and my pants are tight and stuff. So then I usually try and do a longer one, like 3 to 5 days, just to sort of get back into the rhythm of things. And then I don't feel guilty about all the sort of cookies I ate over Christmas time, right? It's like, I know that stuff is not good for me, but you're over at somebody's house and they made cookies for you, and I'm going to enjoy them because I know I can sort of make up for it later on. And that's the sort of power of it, is it can give you a little bit more flexibility sometimes. So that's my personal protocol. It works for me. I mean, you have to see what works for yourself and so on, but it's about building it into sort of a habit, making it sort of automatic so that you don't have to think about it. Like, for example, I have a couple of days of the week that are generally busier, and those days I'll just say, okay, well, those are days I'm not going to eat, right? Eat lunch, I mean. So it's a lot easier that way.
It's very practical. I happen to have almost the same protocol, 24 hours, just because it's practical.
Yeah.
But for doctors, it's very handy.
Yeah.
Well, Dr. Fung, I'd like to say thank you so much for this interview. I hope it's the first of many that are to come. Megan is coming next, so You have 50 seconds to say goodbye, and thank you so much for being here again.
Thank you so much. And, I hope we can do this again, and hopefully we'll get some good information to everybody. And I'll see you then. Okay, bye.
Okay, bye.